Yes.
Okay.
Okay, so
Good
all set.
morning. First, I want to thank Dr. Palumbo, the organized team, the FIBAP team, and all who made this course possible. In the next 20 minutes, I will talk about ultrasound-guided embryo transfer. And I will try to answer the question, can we identify the optimal implantation point? I have no disclosures. And at the conclusion of this presentation, participants should be able to appreciate the benefits of ultrasound-guided embryo transfer procedures, understand the benefits of three-dimensional ultrasound, to assess the localization of the embryo flash and identify the optimal implantation point, and review the general technical aspects of the embryo transfer procedure. We all know that the transfer is the final step of the IVF marathon. And in this moment, we see that it's true that the effort of all IVF team and the patients culminates at this moment. Pregnancy rates are affected by a variety of factors, and difference in embryo transfer procedure, such as the use of ultrasound guidance and the skills of individual providers, may affect success rates. It's estimated that a poor embryo transfer technique may be responsible for 30% of all AVF failures, and we will focus on the importance of the use of ultrasound in embryo transfer and the potential use of 3D and 4D ultrasound to improve our technique. While it's true embryo transfer has been considered more as an art than a protocolized process, it's important to use a standardized protocol because a bad transfer technique can spoil the implantation of a good quality embryo in a receptive endometrium. The embryo transfer technique gradually, and I will say rather slowly, evolved from clinical touch to ultrasound guidance. And now we believe that time has come to introduce 3D and 4D ultrasound guidance. The use of abdominal ultrasound to guide an embryo transfer was first discussed by Strickler back in 1985. He postulated that this would allow an accurate and a traumatic positioning of the catheter tip near the uterine fundus, along with visualization of the injection of the transfer fluid containing the embryo. After Strickler's paper, many publications have addressed this issue, but it was not until 30 years later that a consensus was reached. In this Cochrane systematic review from 2016 that included 21 randomized controlled trials, they conclude that ultrasound guidance embryo transfer improved clinical pregnancy rates compared with clinical touch. Finally, in 2017, the American Society published in this committee opinion that really they recommend the use of ultrasound guidance in embryo transfer with a grade A of recommendation. By allowing identification of cervical canal and endometrial cavity, ultrasound can facilitate a traumatic penetration of the catheter into the uterus, thereby minimizing endometrial trauma. And one of the advantages of ultrasound-guided embryo transfer is that the physician is able to visualize the catheter tip until deposit the drop in the desired distance from the uterus fundus. We can also monitor the final position of the embryo flash with bidimensional ultrasound. And the level of difficulty of embryo transfer has also been subject of investigations. American Society states that there is insufficient evidence to recommend for or against the selected ultrasound anticipated in a difficult embryo transfer. But we all know that difficult embryo transfer may have lower pregnancy than easy transfer. We can see in this video that despite a good quality in two-dimension images, it's difficult to pass the catheter through the cervical canal, And with the guide of abdominal ultrasound, the movement of the speculum to correct the angle of the cervix, the passage is achieved. However, it has been shown that adapting the embryo transfer technique will improve results. We can see in this recent study similar pregnancy rates regardless of whether the transfer was easy or difficult. It has been proposed that patients with a history of extremely difficult embryo transfer may benefit from hysteroscopic evaluation of their cervical canal before a future IVF attempt. We know how to treat these patients through the work of Dr. Janusz Polski in 2000. She published a prospective case series with difficult embryo transfer and demonstrated that the hysteroscopic evaluation of the cervix and placement of a Malekot catheter will help to us in the future IVF attempt. So actually, we leave the catheter, the Malekot catheter in place by 7 to 15 days with antibiotic coverage, and we remove it at the baseline ultrasound. And now, so far we know the use of two-dimensional ultrasound in embryo transfer, and we already know the valuable information that this can offer us. Now I wonder, why live in two dimensions if we can do it in 3D? Remember this metaphor. Living in 3D gives depth to life. Only one randomized controlled trial compared three-dimensional ultrasound with two-dimensional ultrasound. And here we can see in this graph where the blue bars represents three-dimensional ultrasound and red bars represents bidimensional ultrasound, the authors didn't find a significant difference in the ongoing pregnancy, implantation, and clinical pregnancy rates, and even in miscarriage and ectopic pregnancy rate. And this is the first paper addressing the use of 3D and 4D ultrasound guidance during embryo transfer, published in 2005. They evaluated the use of 3D in conjunction with four-dimensional ultrasound, using the maximal implantation potential point in order to facilitate embryo transfer and potentially improve the pregnancy rate. In this paper, the author defined the midpoint as the intersection of two imaginary lines, one originating in each fallopian tube within the inverted triangle of the uterine cavity. So, how do they do it? A 3D ultrasound were performed revealing the uterine cavity and what they consider to be the midpoint. Then, the catheter tip was visualized by two-dimensional ultrasound during the entire insertion of the catheter procedure. And once the internal os was passed, the 4D mode was employed. Once the tip of the catheter reached the midpoint, the embryos were released and an embryo flash was visualized. It's still unclear that what is the ideal point of this midpoint. And it's difficult because when we compare the studies examining this optimal implantation point, some studies assess with an exact distance from the uterine cavity, from the fundus, and another divide the uterine cavity in areas. And there may be an influence of the length of the uterine cavity. Finally, the American Society states that embryo transfer catheter placement affects implantation and pregnancy rates, and the placement of the catheter tip into the upper or middle central area of the uterine cavity optimizes pregnancy rates. These results prompt us to conduct the following study that we presented more than 10 years ago at an American Society meeting to test the hypothesis that implantation rate change as a function of the placement of the embryos in the uterine cavity, visualized by three-dimensional ultrasound. We conducted a prospective study of 78 egg donation patients. All transfer were under bidimensional ultrasound guidance, and a 3D volume was acquired immediately after the transfer and stored for subsequent evaluation by two blinded investigators. The following measures were recorded and in the coronal view looking for the midpoint. Implantation and pregnancy rate were determined. With this slide, I just want to show you how we do this ultrasound. We made the transfer with two-dimensional ultrasound guide until deposit the drop in the uterine cavity, and immediately we use three-dimensional ultrasound to make the measurement in the coronal view and two in the sagittal plane. We can see how we make the measure from the center of the drop to the fundus, to the right and to the left ostium, and finally to the internal cervical os. And in the sagittal plane, we make the thickness of the endometrium, the distance from the drop to the fundus, from the drop to the internal cervical os, and all the length of the cavity, of the uterine cavity. So 3D ultrasound allows us to visualize the embryo flash and identify the final position of the embryo flash in the coronal plane. About our results, reported that the implantation rate is higher when the embryo is deposited at 9 millimeters from the uterine fundus, an equidistance to the ostia. Based on this study, we have modified our embryo transfer technique with the intention to deposit the embryo, the drop, as close as possible to this ideal maximal implantation point. And the next point is about our knowledge of embryo placement and the development of the gestational sac. From the year 2000 was reported that 80% of embryo implants where the embryo were originally deposited. Studies assessing this relationship and the position of the air bubbles following the embryo transfer show conflicting results. Saralevos in 2016 showed that embryos can move following the transfer, and that those moving towards the fundus had higher pregnancy compared with that moving to the cervix. We also addressed this issue and correlated the position of the embryo flash with the position of the gestational sac, and we presented at the last meeting of the Spanish Fertility Society. We conducted a prospective study of 232 ultrasound-guided embryo transfer of a single fresh blastocyst in oocyte donation patients. A 3D volume of the uterus was acquired immediately post-transfer, and in a subgroup of 109 pregnant patients, a 3D ultrasound was done at 5 weeks of gestation to identify the gestational sac and stored for subsequent evaluation by two blinded investigators. The localization of the gestational sac was compared with the embryo flash placement, performing the same measurements like you can see in the coronal view with the embryo flash and with the gestational sac. Here we can see how we make the measurements in the coronal plane in both cases, with the embryo flash and with the gestational sac at 5 weeks of pregnancy in the first ultrasound. Our results and conclusions: the mean distance from embryo flash to the fundus was 9 millimeters, and the mean distance from the gestational sac to the fundus was 11 millimeters, and no lateral displacement of the embryos were observed. Our results suggest that embryo moved towards the internal cervical os before implantation, and it could be simple by a consequence of a uterine growth in the first trimester of the pregnancy, but it's possible too because uterine peristalsis, and that will be addressed by Dr. Moliner in the next presentation. We have recently started to investigate four-dimensional ultrasound as guidance in embryo transfer. The vision of the drop in most cases is well appreciated. However, we found limitations for the visualization of the catheter tip. Even we have a two-dimensional ultrasound to guide us to the entry into the uterine cavity. For the ultrasound offer us too the possibility to study the final position of the drop in the coronal plane and the maximal implantation point. In summary, evidence is not yet available to demonstrate improved results with 3D ultrasound, and further research is needed. But we can see the potential advantage that 3D and 4D ultrasound guidance, and that include the capability to evaluate the depth and assess the coronal plane view. We can perform studies to better define what and where is this ideal maximal implantation point, and the ability to store volumes and reevaluate them at a later time with a teaching and knowledge proposed. And finally, all these may be useful to improve our embryo transfer technique. Limitations of 3D and 4D ultrasound are the need to improve the technical aspect of in vivo guidance, for example, the speed and the quality of the images. The final position of the air bubbles depend on various factors, and at present it is not possible to predict the exact position where the flash will go after the transfer, and we have to assume that the bubble represents the embryo. Even with 4D ultrasound guidance, we have limited to move in the lateral planes. And the need for a specific training in four-dimensional ultrasound is another limitation. About the technical aspect of the embryo transfer procedure, the American Society guidelines recommend to make emphasis on the development and implementation of embryo transfer simulator, characterization of current embryo transfer practices, and comparison with evidence-based best practices. And that is what we have been doing during all this course, this practical theoretical course. And those are the interventions are supported by literature for improving pregnancy rates. Abdominal ultrasound guidance for embryo transfer with a grade A of recommendation, removal of the cervical mucus, use a soft transfer catheter, placement the embryo transfer tip in the upper or middle central area of the uterine cavity, greater than 1 centimeter from the fundus for embryo expulsion. Expel the embryo and withdraw immediately the catheter. Check the catheter for retained embryos and, if present, reload new catheter and immediately retransfer the embryo. And an immediate ambulation once the transfer procedure is completed. The messages that we want you to take home in addition to learning objectives are: ultrasound has become an indispensable tool to monitor, guide, and verify our embryo transfer procedures. And important, patients feel comfortable having the ability to visualize the final step of a difficult process. The use of ultrasound guidance is an integral part of a perfect embryo transfer technique and is only expanding and may include 3D and 4D ultrasound guidance. And to answer our initial questions, yes, I believe and we believe that we can identify the optimal implantation point. We will continue to work to investigate the possibility of 3D and 4D ultrasound guidance on embryo transfer, and day by day we are looking for new applications of the different tools that this can offer us, as you have seen along this course. Thank you very much.